Dr. Trolice tonight. He is an avid blogger. He's a father of 5. Count them, 1, 2, 3, 4, 5. He's really passionate about what he does. And what I love about working with Dr. Trolice is that if you have a goal of starting a family, this is the guy you want to work with. He's highly successful. Here in Central Florida, he's the most successful physician in IVF. So you are here with an expert tonight. He's passionate about your cause, and whatever questions you may have, we have time for that as well. But first, let me introduce Dr. Trolice up here so he can talk to you a little bit about building your family.
Thank you all. I appreciate the invitation and the kind words, Kareem. Thank you. And I also want to thank you all for coming out to talk about fertility. You know, it's not an easy topic. And to share this with others can be a little bit awkward, but I congratulate you for taking that step to do that, because what you're doing is you're taking charge of your fertility. You're doing a proactive approach to something that's been a little bit challenging. So tonight, what I thought we would do is just talk about basics, but also want you to feel comfortable asking questions. If the topic comes up and that you want to have a little bit more clarification, just raise your hand. Certainly if it's a very difficult question, we'll just ignore it. But what we're going to do is try to do all the, to answer all of your concerns as much as possible. So with that, this particular topic tonight is about Fertility 101. And it sort of gives you the idea that we're going to talk about the basics. And so most people think that, you know, when you're ready to start a family, how do you do that? Well, typically it's candles and wine and things like that. But the basics of fertility are really 3 things. Okay? Can anybody think of the 3 most important factors that we need to establish a pregnancy? Yeah, you do need men, so there. I mean, really just for this stuff. And then you can make the decision after that. But okay, so men, sperm rather, and
good eggs.
Yeah, definitely need a good egg.
Uterus.
You need a uterus, but along the same path, anatomically, what else do we need? Right, we need open fallopian tubes, and that's the basics of fertility. Okay, so when we see a patient that's coming along, well, why don't we just even talk about what we consider an issue, okay? Typically, fertility is defined as 1 year of not being able to conceive in a woman that has monthly cycles, okay, and no other predisposing factors, okay? That's a long definition, long-winded definition, but it's really important to underscore the fact that if there's any red flags before, then just get seen and evaluated. I saw one the other day, and she says, you know, I'm just so over this, I've been trying for 3 years. Well, she gets 1 or 2 periods a year. She hasn't really been trying, she hasn't been in the game. She has been wanting to get pregnant, but she really hasn't had a fair chance. So in order to start the clock, if you will, of trying to conceive, we need to have, we actually have a heckler. Who would imagine the smallest one in the room having a heckler? But what we really need, though, is to give everybody an even playing field. So 1 year of no predisposing factors, unprotected intercourse in a woman less than 35 who has regular menstrual cycles. Okay? Now, when women are above 35, we recommend 6 months of attempts. And in a woman above 39, you know, 40 and above, we say 3 months. The reason why we make those statements is because, as every woman in this room knows, and they don't want to hear me even go near that topic, is that as a woman gets older, it becomes more difficult to conceive. Okay? These cutoff points that we talk about, 1 year, 6 months, and 3 months, this is not midnight of 1 year of attempts and that's it, call 911 because it ain't gonna happen, I need help. No, we're not talking about that, okay? It can still happen. As a matter of fact, if you do a full evaluation, after about 3 to 5 years with a full evaluation that's normal, 60% of patients will conceive. Now when I tell a patient that who comes to see me, and I start saying 3 to 5 years, they say, thanks for the information, let's get going. But I just do that in a way to say that it can still happen even if we do an evaluation and we don't find anything, and it's been more than a year, okay? More than a year does not mean it won't happen naturally, okay? And as a matter of fact, in Europe, they look at 2 years of trying to conceive, okay? So I want to give you that hope and encouragement. Why above 35 and then why above 39 do we start making the time toward getting an evaluation shorter is because of the biologic clock, okay? We're going to talk about the biologic clock in the next talk, but I just wanted to give you a heads up about that, something of concern. So, what do we look at when we start seeing couples that are trying to conceive? Okay, we'll talk about couples because we know that there are single women and same-sex couples. We're going to talk about heterosexual couples right now to do a full evaluation. Okay, so we look at things that are involving the man and the woman. Before I mention that, what do you all think after a year of trying? What do you all think the percentages are of causes of fertility? Anybody know what the chance, after a year of trying to conceive, what the chance that we find a male factor? I'll preface this by saying that everybody says 90% female, 10% male at best. So, and the men say probably 1 to 2% of the male factor. Let's not even go into that issue. But nevertheless, all the guys are giving me dirty looks and all the women say, yeah, that's exactly what it feels. So, when we talk about this, what chance do you think that we find a male factor?
25, 40%, 40.
I felt like there was an auction for a second there. I was wondering, 45, 50, 55? Anyway, it's about 40%. 40%. Who got it? You said 40%? What does she get, Corinne? Does she get anything? We'll get prizes over later. But so 40%, excellent, okay? What's the chance that we find a female factor? 40. Exactly. Very few people are aware that it's equal. Isn't that amazing? When you talk to friends or family, it's something that is just not well known, but it is equal. 20%, if we round up now, we add up to 100, 20% is unexplained, and then 30% is some sort of combination factors, okay? So, now we know what we're dealing with in terms of the causes. Let's just talk about the male issue. How can we do, what's the best way to screen for a male? Is a sperm analysis, okay? Sometimes the wife has to lasso and rope the man in to come in for the sperm analysis. Sometimes it's with gentle prodding, sometimes it's actual threats. So, nevertheless, we do eventually get the man to come in and do a sperm analysis, okay? We don't ask how that happened, but we just are grateful that it does occur. Usually, after the sperm analysis is typically the only time we get the phone call from the man, okay? And it starts about 6 minutes after the analysis. Do we have the results then? So you just actually dropped a couple. Yeah, but how's it looking? And so usually about every 6 to 10 minutes until we can get the results back. So it's anxiety provoking, and we understand that. It's also interesting that the reaction of the test results are different among the man and the woman. The woman is desperate to find out why. If her tube is blocked, I'm not ovulating, tell me something. If the man is told that there is 1 percentage point abnormal in the sperm analysis, we usually have the priest and the fireman with the megaphone. Sir, it's not that bad. Please just come down. It becomes much more difficult. But we have to understand that because it's cultural differences and it's also differences amongst the sexes. Nevertheless, what do we look at in the sperm analysis? 3 simple things. I know there's a lot of information when you get the report of the sperm analysis, but all we're looking on are 3 different things, okay? We're looking at the actual density of the sperm, the count. And I'm going to preface this by saying that the World Health Organization, several years ago, has come out with a new edition. It's the 5th edition. a lot of the clinics that you'll see and a lot of the laboratories are still using outdated numbers. What I mean to say is that when the men come to see us and are being told that they have an abnormal sperm analysis, we're actually correcting that and saying, no, this is now acceptable, okay? A sperm analysis is not a yes or no. A sperm analysis tells us, in the 95% of men, does your sperm analysis fall into that? That does not mean that if it's a little bit below that, no chance of pregnancy, we need donor sperm. I'm not saying that at all, okay? But we're looking at what's the majority of the men that's going to be within the 95%. The density of the sperm is millions per milliliter, okay? Less than 20 million per milliliter used to be, now it's 15 million per milliliter, okay? The motility of the sperm, how they're moving, used to be 50% or more. Now we look at 40% or more, okay? And then the shapes of the sperm. The shapes of the sperm is literally how the sperm look, okay? And it used to be 30% or more was considered normal. Now it's 4%, okay? So you might be given old, outdated information about a sperm analysis, and that needs to be updated, okay? If we get an abnormal sperm analysis, we just repeat it. Because we go back to basic biology, and we know that there's a difference between men and women, okay? The woman is born with all the eggs she's ever gonna have. A man starts making sperm at the time of puberty, and that continues thereafter, okay? So, sperm take about 72 days to mature, over a 3-month time. So if we do a sperm analysis and that's abnormal, anything that happened over the last 3 months, virus, medication, increased temperature at the testes, anything that could be causing that could be influencing the sperm analysis, so we repeat it. One sperm analysis should not make a diagnosis, okay? So we repeat the sperm analysis, and then we go on from there. If it's normal, then we're obviously reassured. If it remains abnormal, then we need to have the man see a urologist, because the urologist is going to take a look at anatomical problem, is it a hormonal problem, is it a genetic problem. I want to underscore this point, because if the sperm analysis is abnormal, I've seen patients come to us where the man is just recommended, oh, let's just do in vitro fertilization and that'll take care of that. But it's very important that if the man's sperm analysis is significantly abnormal, they need a genital examination by a urologist. And the reason is because the abnormal sperm analysis may be the first sign of significant concern medically, like a testicular tumor. When I was training, we diagnosed a man with that problem. So in 1 to maybe 2% of men with severe sperm problems, they could be having that as a result of tumor. Treated, okay? Abnormal sperm analysis, very simple. If everything is normal in terms of the examination and hormones, then a very simple treatment could be artificial insemination. And artificial insemination is basically where a man produces sperm, the laboratory washes the sperm and concentrates it, and then we just pass that through a woman's cervix into the uterus. Very simple procedure that's done right in the office, okay? It should be combined with fertility medication usually. The only time that you would ever do artificial insemination without any fertility medication is if it's a single woman who doesn't have sperm and they're using donor sperm, or if there's a problem with intercourse. Otherwise, you really want to combine artificial insemination with fertility medication. So artificial insemination, intrauterine insemination, or IUI, all the same thing, okay? So if the man's sperm analysis is severely abnormal, or there's hormonal issues, men are sometimes treated with cloma, just like a woman. Clomiphene citrate works in a way to override and trick the brain, so signals are going to the testes to increase sperm production, okay? If there's severely abnormal sperm analysis that's not responding to fertility medication, in vitro fertilization with an advanced technique called ICSI. Anybody know what ICSI is? Heard of ICSI? Yeah. ICSI, everything in my field is the alphabet soup. We just have trouble, I guess, pronouncing things, so we have to abbreviate them all. So ICSI takes a single sperm microscopically and injects it through the outer membrane of the egg for fertilization. Do you know how ICSI was first discovered? In Belgium, Dr. Palermo was doing a procedure. Up until that time, what they were doing with abnormal sperm analysis was just pushing the sperm through the outer layers of the egg and then letting it sort of make its way through there. So they had this partial zonal dissection and then subzonal insertion where you were making a little bit of an entry under the zona of the egg. Well, Dr. Palermo went too far. He actually went through the membrane into what's called the cytoplasm. And in the cytoplasm is also the nucleus. So he said, oh my gosh, I think I ruined this. I actually talked to him about how he did this. So he pushed that egg to the side thinking that he ruined that egg. But he watched it over time and it developed normally. And ICSI was born in that way. Okay, so we can use ICSI, and it's been around since the mid-1990s, and essentially evens the playing field for a man's sperm if it's abnormal. ICSI has the same pregnancy rates whether you use it or not with an in vitro fertilization cycle. Okay? So that's basically the male. Any questions about the male before we jump over to the female? Okay, so for the female, the most important, two most important factors to evaluate. Is she ovulating? And are her fallopian tubes open? Okay? Very simple tests. Is she ovulating? You can determine this by doing a home ovulation predictor kit. You test the woman's urine, and you're able to determine that by the color change. You don't have to get the thousands of dollars worth of your ovulation predictor kit. Get the very inexpensive one, $10, $11, okay? Important to note when to have relations. If you're using an ovulation predictor kit, when to have relations. Last time I gave this talk, a man said 10 p.m. You know, different times, I guess, for different people, but what I mean by this is that when in the cycle to have relations, and what a lot of people are not aware is that if you're having a urine surge of hormone that you're ovulating, the 6 days preceding ovulation is most optimal for fertility. So if it's day 14 of your cycle, then day 9, 10, 11, 12, 13, 14, every day, just kidding, to every other day up until the day of ovulation. That's key, okay? So, ovulation, and then what else? Hysterosalpingogram is the most standardized test to determine if a woman's fallopian tubes are open, or the HSG. And that's where you inject dye. It's a very simple office procedure. You inject dye through a woman's cervix, up into the uterus, and down the fallopian tubes. And you know right then if the fallopian tubes are open or not. Quick point about an abnormal fallopian tube. If a tube is blocked, it's not always, well, the other tube is open, let's see if we can get pregnant. There is a specific type of blockage called a hydrosalpinx. Hydrosalpinx is a blocked swollen tube, and that can actually cause fluid accumulation in the fallopian tube, seeps back into the uterus, and reduces implantation probably up to 50%. So we want to take care of that, because taking care of that, even removing that tube, makes the other tube optimal. So now we have the evaluation. Options are fertility medication. Now, if a woman doesn't ovulate, the goal is to get them to ovulate. 1 or 2 follicles to develop to produce an egg. If the woman is ovulating already, the goal is to superovulate. 2, 3, 4 follicles to up the odds. Now, of course, with fertility medication, the goal is not to end up on Oprah, right? There's always a risk of multiple births, but that's not our goal. But it is inherent whenever you use fertility medication, there is a risk of multiple births. And your doctor who's monitoring you needs to make you aware of that risk, particularly if it's getting over the acceptable level. We just had a patient, 41 years old. We were doing an IUI, and we gave her some reasonable stimulation. She's producing multiple follicles, 6, 7, 8 follicles. So I said, you know, we have to have a little talk here. I said, you're producing a lot of follicles. That's the good news, but the not so good news is that if these all release inside you, you could really end up with a significant high order multiple birth. So we gave her the option of not continuing, but she chose actually to convert to in vitro fertilization. We got 16 eggs, and she's doing well, and we should be transferring her in the next day or so. So keep my fingers crossed there. Okay, so we have fertility medication with artificial insemination. Usually about 3 cycles, the majority of patients will conceive. After 3 cycles, we start seeing a lower pregnancy rate with each subsequent IUI. And the option at that point would either be to do a laparoscopy or go to in vitro fertilization. Laparoscopy used to be done on all fertility patients. It should not be done as much any longer, unless there's really a good indication. Because the chance of a woman who's never had a pelvic infection, prior extensive surgery, history of sexually transmitted infection, or abnormal fallopian tubes on the HSG, the chance of abnormality on laparoscopy is less than 30%. So you really shouldn't be doing laparoscopy any longer. I know patients come to me that their doctor is recommending laparoscopy because they see a little bit of fluid on the ultrasound. That is not an indication for a laparoscopy, okay? So buyer beware, we have to be careful about the type of evaluation and testing. In vitro fertilization is definitely the highest chance of success, the most aggressive, but also the most expensive. Unfortunately, in Florida, we don't have great coverage for fertility. So it's something where you just have to think about what type of physical, emotional, and financial investment you want to put into your fertility. IVF, obviously, the most involved, the most optimistic type of treatment, but it is clearly not for everyone for various reasons. Nevertheless, your doctor should speak with you about all of those options and find out what's best for you and educate you so you can feel empowered to take charge of your fertility. I just saw a patient a few hours ago. Her doctor did 3 IUI cycles. She went to another fertility clinic and they were all ready to go to IVF. She came to me. We talked about all the different options I just talked about right now. She said no one ever spoke about these type of things. I still am thinking about IVF, but I'm glad I know now that there are options and I want to make that decision. So I thank you for your time today. I hope I didn't take too long. I wanted to give you a basic understanding about fertility, but I also want to open it up for a few questions before I sign off. And I know you have questions, and if you don't, I'll start calling on you. Okay.